Hello, welcome to HLA Live. HLA Live is our regular broadcast on the HLA YouTube channel as well as all the other social media channels. Each week we talk to interesting people from across the HLA community.
Good evening, everyone. I am really excited to be chairing tonight's meeting.
Hi, I'm Rosie Spooner and I'm hosting HLA Live this Wednesday.
And I'm an HLA scholar and I'm also going to be your host this evening.
To share with us their ideas and their innovations and hopefully bring them to a global audience.
Quite quick, we have ideas, let's do this, let's do that. So
many of the topics come from our community, with scholars and faculty expressing an interest in many of the discussions that we're about to have.
Hello everyone and welcome to the HLA Live session on widening participation in the postgraduate realm.
Homelessness and health.
Addiction and the new normal.
HLA programs are built on 6 pillars. The leader is an innovator and entrepreneur. The leader is a communicator. The leader is a manager. The leader as a negotiator. The leader as a follower. And the leader as a philosopher. If you are interested in becoming a HLA scholar, why not get in contact? Many of the episodes in HLA Live will cover one or more of these important pillars. The HLA team consists of Pedra, Eamon, Tim, Riddy, Alistair, Adil and Trisha, and a range of other HLA scholars and faculty.
Thank you for asking me to come along today. My name is Mike Farker. I'm a consultant in sleep medicine at Evelyn at London Children's Hospital. But I have a long-standing interest in talking about the impact of sleep deprivation and fatigue on the people who are here to provide NHS care. And what I'm going to do over the next 20-25 minutes or so is give you a brief introduction to some of the reasons why I think this is important and some of the things that I think we should be doing both as individuals, but more importantly, from a systemic point of view to try and help to deal with this. My starting point into all of this, I am a sleep physician. I'm a children's sleep physician as it happens. So my starting point into all of this when I became a consultant was to try and help people who work shifts, particularly night shifts, to think better about their sleep, because we know that when people work around the clock, sleep becomes significantly affected. Sleep is absolutely fundamental to every aspect of our physical and mental health. We spend overall about a third of our lives asleep. And we know there is a growing body of evidence that tells us that when we are sleep deprived or we have poor sleep quality, that can affect almost every aspect of our physical and mental health. One of the things I love about being a sleep physician is that we're constantly finding new ways that sleep supports how we function, how we feel, how we do everything that we do. But we know quite a lot now about how and why sleep is so important to us. I can literally talk to you for the entire day about sleep and why it's so important to you. But one of the most simple ways to think about this is that if you think of your brain and body as a complex piece of biological machinery, like any bit of machinery, that requires regular maintenance, regular repair. And if you have a piece of machinery like a car, you will need to do regular maintenance, regular repair, take it in for regular MOT checks to make sure that the car keeps working as well as it can be. If you skimp the maintenance, if you don't do the repairs, then your car will probably keep running for a while. But the longer you skip out the maintenance, the longer you skip the repairs, the more problems will build up and the more difficult and more expensive they will become for you to fix. This is exactly what sleep is doing for you every single night of your life. It is that regular repair and maintenance that is keeping your brain and body functioning at its best as much as we can. Even before we start thinking about people in organisations like the NHS where sleep becomes much more challenging, we know that actually the experience of most adults in countries like the UK is that most of you are probably already sleep deprived even before we start thinking about the jobs that you're doing. When we look at the data that tells us about how much sleep adults in countries like ours get, most adults are probably missing about an hour of sleep every night on average. As an adult, you should be getting approximately 7 to 8 hours of sleep per night. Everybody's a bit different. And most of you are probably getting 6 or 7 hours of sleep per night. When you say it like that, it doesn't sound very much. You're missing an hour of sleep every night. What's the big deal? But if you think about that in a slightly different way, if you are missing an hour of sleep every night of your life and you're meant to get 7 or 8 hours of sleep per night, then that means over the course of a week, you are missing the equivalent of an entire night's sleep. And once you start thinking about it in that way, you can start to see that it is likely that this is going to have an impact on how you are able to function, how you feel, how you're able to come and do your job. So one of the most important things when we're thinking about this is we have to acknowledge that probably you are sleep deprived already. What we then do for many staff in the NHS, so as well as working in often pressured environments where stakes are high and there's often lots to do all the time, lots of stress, for many people who work in the NHS, we have to provide 24-hour-a-day care. What that means is we then have to plug you into rotas where you have to be wide awake at 3 o'clock in the morning, providing care to the standards of the NHS, when every single cell in your brain and body is telling you that you are meant to be asleep. Physiologically, that is exactly the same process as if you have gone on holiday, if you can remember when we were allowed to do that, far enough around the world to become jet lagged. And most of you, I'm sure, will have had the experience of being jet lagged at some point. And when we're jet lagged, when our body clocks are out of sync with the time where we happen to be, we feel the effects of that. We feel the physical consequences, we feel the mental consequences of that. We don't function at our best when we are jet lagged. But physiologically, when we ask people to work around the clock, when we plug people into rotas that has them providing high quality care at 3 o'clock in the morning, physiologically, we are asking them to do exactly the same as if they were being asked to work when jet lagged. And that gets to the real heart of night shift working in particular, that at 3 o'clock in the morning, our brain's body clock expects us to be asleep. And fighting against that is something that takes a lot of energy and can be very difficult to do and gives that 3, 4 o'clock in the morning feeling that most people are familiar with when you feel at your absolute lowest when doing a night shift. There are lots of consequences of taking into account these very simple principles. And when I started doing this work, one of the reasons that I really wanted to begin to do work in this area is because of stories like these. These are junior doctors and nurses who have crashed and died just trying to get home after a night shift. They weren't working rotas that were particularly unusual. They were working the normal kind of patterns that we ask when people have to provide care around the clock. And when you are working at night, when you are fatigued, when you are not getting sleep, when you're working against your body clock, that begins to accumulate in terms of fatigue. And if you get behind the wheel of a car when you are fatigued, you are at significant risk of having a road traffic accident. And probably on average, about every 6 months or so, I see a story like this in local newspapers. It never makes the national news, where a doctor, a nurse has crashed and died because they've probably fallen asleep just for seconds behind the wheel of a car driving home, and they've paid the ultimate cost for just the job that we are here to do. We cannot reduce these risks to zero, but I think we do have a huge responsibility to be more aware of these risks and to try to do everything we possibly can to mitigate and reduce the risk of these types of outcome as much as we possibly can. Death is the most severe consequence of this pattern, this effect of fatigue. But actually, when we start to look at the other consequences, there is lots of good data that tells us that when we ask people to work around the clock, when we ask them to work in a way that is going to make them sleep deprived, make them fatigued, and affect the amount of sleep they get, that also has a consequence. And there's lots of good evidence that tells us that for people who work regular shifts, your risk of type 2 diabetes goes up, your risk of obesity goes up, your risk of cardiovascular disease, so high blood pressure, strokes, heart attacks goes up, your risk of some type of cancers goes up, your risk of mental health problems such as anxiety and depression goes up. So just asking somebody to work shifts is asking them to do something that is bad for their health. The link is there. This is a systematic review from the BMJ from a few years ago now that pulls together a lot of the evidence at that point that is available around this. This is something that I think everybody who works shifts should be aware of. But more importantly than that, I think this is something that every single person who asks people to work shifts, every employer, every manager, everybody who is putting people onto rotas where they're working around the clock, they need to be aware of the human cost of what they are asking people to do, and then to put in place strategies to mitigate this as much as we possibly can. Although when I started doing this work, I was very much focused on night shifts. Actually, once you start talking about sleep and sleep deprivation, fatigue in the context of the NHS, you quite quickly become aware that fatigue is not just related to night shifts. Fatigue is a problem that is affecting many of us most of the time when we are thinking about the work that we are here to do. This is data from the GMC Doctors Survey, which surveys doctors in training and their trainers every year. And we've been putting in questions into this over the last few years that try and capture some of this data. So when we ask people, do you feel tired enough in the daytime that it impacts your ability to do your job? About a fifth of doctors in training and their trainers say, yep, that sounds like me. Fatigue is something that is there around the clock, and it can have a really big impact on the care that we deliver, as well as on our own health and well-being. What impact does it have? Again, none of this is rocket science. Everybody knows this as soon as you say it. If you're tired, you're more likely to make a mistake. And in environments like the NHS, if we make a mistake, the consequences can be very significant. I'm a paediatrician by training. I spent a significant amount of time in neonatal intensive care units as a trainee. If you are tired and you make a decimal point error at 3 o'clock in the morning when doing a drug calculation, you can kill a baby. So we know that mistakes can have severe consequences in environments like the NHS. We have lots of good data from other professions that tells us that if we look at the risk of accidents or mistakes in the workplace, if you are working up to 8 hours or beyond 8 hours, your risk of an accident goes up significantly. More relevant than that, when we look at shifts in the NHS, which are often 12, 13 hours in length, if you go from 8 hours to 12 hours, your risk of an accident is likely to double during that time. Our risk of making a mistake or an error goes up significantly when we look at longer shifts, which tend to be the norm in the context of the NHS. This all relates to how we are able to perform when we are functioning under stress or pressure. This is the performance curve, which is something that is used very much by athletes, sports medicine, to try and work out how they get the best performance for the amount of training that they are putting in. If you talk to professional athletes, you will know that they will train to a point and then they stop and relax. They train, they stop, they train, they stop. Because what they are doing is trying to keep their performance levels at the optimal level, kind of circling around the top of this graph. They know that if they just train and train and train and train and train, there comes a point where their performance doesn't improve and actually it starts to drop off after a point. So getting the balance right between the amount of pressure, the amount of work that we're putting into something and our performance is really important. In the NHS, we tend to give people the impression that the performance is expected to continue along that dotted line at the top, no matter what the stress or pressure is. There are 20 people still to be seen in the ED waiting room. You just need to carry on working to clear them. But we know all of the data tells us that when people continue to function, when they push themselves beyond the point where they should probably have stopped and taken a break, that actually their performance does not maintain and actually it will start to drop off and decay. If you model that over a shift, you can see people working less efficiently. If you model it over a career, what we start to see is the consequences of people functioning beyond their limits. Too often, we see them starting to become sick, going off with stress-related illnesses. We see them burning out if we don't get this balance right. For all those reasons, therefore, we think it's important that we should get to a point where we stop and think about these and how can we try and make these issues more obvious and how people can do things to start to try and improve them. When I started doing work around this, I first of all focused on trying to support the individuals working shifts. And what we do is, so for every new doctor, every new student nurse that comes to our hospital, they get an hour of teaching from me that is all about their sleep and how they can work better through shifts in particular. And what I do is I talk to them about the basics of sleep, how to get your bedroom as good as possible for good sleep, both by day and by night. We talk to them about good sleep habits, good sleep routines, how to try and get your sleep quality and quantity as good as it possibly can be. We talk to them about working through shifts and strategies to try and help to make that better. So for example, how to use things like caffeine sensibly to manage tiredness on a shift, but also so as not to impact the quality of sleep you get home. We talk to them about how to manage that risk of getting home. So we try and encourage people to think really clearly about whether they're safe to get behind the wheel of a car before they drive home. And if they are going home, there are simple hacks like sticking on sunglasses when you come out into the morning light after a night shift that try and help to affect the body clock to try and make sure the quality of sleep that you get is as good as possible when you're trying to sleep in the daytime. And we talk to them about recovery. So if they are on a night shift and they finish on a Monday night and they're expected back on a day shift on a Wednesday night, we talk to them about strategies about how to try and optimize that as much as possible. We've looked at this training over the last few years, and about 3/4 of people who receive this training come back and say to us, well, actually, I've made changes to my sleep or to how I work shifts that have improved my ability to work in the way that I do. So people tend to value even something as simple as that. People tend to value it as something that helps them to work a bit better. The details of all of that recommendation, so I say that usually takes about an hour going through that as a teaching session, but this is intended to be a read about 15 minutes that covers all of those points. So if you're interested in trying to hack your own sleep to work better for shifts, this paper covers that. That is the individual kind of response though, and actually the individual response to this is only a relatively small part of the overall way that we need to think about this. We know, so even before the pandemic came along, we know that looking around our colleagues in the NHS, that burnout is an increasing problem. We are seeing the consequences of staff working in an NHS which has been chronically under-resourced, where staff fill in the gaps from their own personal reserves to try and make sure that we continue to provide best quality care. And we know, exactly as the same as with the performance curve, we know that when people push themselves beyond their natural limits all of the time, that has consequences. Again, data from the GMC survey, we're starting to ask questions that ask trainees to tell us about things that would indicate that they might be suffering from burnout. And across all specialties, the average rate of return to those questions suggests that about a quarter of doctors in training in the UK pre-pandemic were already reporting symptoms that would be consistent with burnout. And this is a problem. When staff are burnt out, when they come off rotas, when they leave the profession, we often struggle to replace them. And that just means things get even more difficult for the people that are left. So we have to think about the systemic response, the systemic support to things like this. The word that often follows hot on the heels of burnout is resilience, and resilience is a word that often creates a very visceral response to people these days. Resilience at its worst is thrown at people as basically the equivalent of you just need to toughen up and cope better and everything will be all right. And clearly that is a really toxic way to think about a problem when the issues are systemic under-resourcing and being able to cope with that. The difficulty, though, is that there is some value in resilience, and me spending an hour talking to people about their sleep, how to improve their sleep quality, how to work better around shifts, is actually resilience training. I very rarely call it that because it just upsets people. But resilience is part of the solution. We can give people better individual skills to cope with the job that we're asking them to do, but it is only ever part of the solution. And in my books, it is the smaller part of the solution compared to the systemic responsibilities. What can we do systemically? In our trust, so I work for Guy's and St Thomas's in London. So a few years ago, we put in place a campaign across our hospital sites called HALT, which is all about encouraging people to think about the importance of rest and breaks. In the NHS, we have got to a point, I think, where many of us view a shift where we get a rest or a break as a luxury. We think, oh, that was lovely. I got a bonus break this shift. That's not something I expect to get. And actually what we've forgotten is that rest and breaks are essential to the care that we deliver. If we are going to carry on functioning at the top of that performance curve, if we are going to be delivering the best quality care to our patients, if we're going to be reducing that risk of error and mistake that creeps in, particularly when we work long shifts, it is absolutely essential that we take regular rest and breaks. So what the HALT campaign is all about is trying to reframe that way that we think about rest and breaks across our trust. It's about saying, if we're going to deliver the best quality care to our patients and look after our staff, it's actually essential that you get the rest and breaks that you are entitled to. And that concept is one that people often struggle with. You know, when you've got 20 people in the waiting room, the idea that actually the most important thing right now might be for you to go and take a break and have a cup of tea and a Kit Kat is one that people often struggle with. So we have to do a lot of work about trying to reframe that, change that way of thinking for staff within the NHS. That often goes hand in hand with another problem in the NHS, which is that we create this culture in the NHS where people think that they should be able to function at superhuman standards. And often, if we can function at superhuman standards, we feel like we've somehow failed. If we weren't able to go a whole 12-hour shift without having to stop and take a break, and it was really busy, and then there's people to hand over to the next shift, we somehow feel like we've failed. And we create this expectation that people are holding themselves to standards that are just impossible to achieve. Your physiology is boringly normal. You are not superhuman, and we should not be creating these artificial standards where people are expected to function above the level that they are capable of doing. Several years ago in our trust, we used to give out a tote bag to our nursing staff that said, what's your superpower? Mine's I'm a GSTT nurse. And people kind of liked it. It was that real validation, that recognition of how recognized your effort was. But if you turn that statement around, if you are not superhuman, you are not good enough to work in our trust. And as soon as you say it in that way, you begin to see just how corrosive an attitude this can be. And we don't give out those bags anymore. We've withdrawn those. But that idea that we are somehow expected to be held to a higher standard is, again, one that is quite endemic in the NHS. When I started as a medical student, one of the very first books I was told to read was The House of God. This is a fiction book. It's from the late 70s. It talks about junior doctors in the American medical system, and their life was pretty rubbish. American system's different to ours. The 70s were a long time ago, but actually a lot of the themes are still very similar. One of the reasons I really like this book now is that one of the characters in it has this slightly plaintive call at one point. How can we care for patients if nobody cares for us? And this again is something that I think we've lost sight of within the NHS for a long time. We don't think about our own health and well-being as being an essential component of the care that we deliver. That's beginning to change. In early 2019, Health Education England published the report here, the Mental Wellbeing Commission report, looking at things that supported or were important to the mental health and well-being of NHS staff. And in that report, they asked the exact same question: who cares for the people, who cares for the nation's health? And they were beginning to change the way that people are thinking about this, to say, if we don't do this, we cannot provide best quality care. At the end of 2019, the GMC published a report that they had commissioned looking at doctors this time, but looking at the impact of doctors' working environments on the care that they deliver. And one of the top level quotes from Michael West, one of the authors, was this: we can't simply go on the way we are, loading more responsibility onto doctors already struggling to cope. Where workloads are excessive, patient care suffers. And again, it's about reframing and making that point that looking after staff is essential to the care that we deliver. At the end of 2019, beginning of 2020, I thought we were in quite a good place to be thinking about these kind of things, that we were beginning to get that point across. And I was quite optimistic that 2020 was going to be a year that we were going to be able to really build on that. And then, of course, along came the coronavirus pandemic, which kind of threw everybody's plans for 2020 out the window. However, one of the things that came through really strongly in the response to the pandemic right from the very beginning was that looking after staff well-being was going to be absolutely essential. Myself, along with one of my colleagues, Srini Yunadkat, who's a psychologist who was in our team at the time, and along with many other people, wrote pieces like this in the BMJ right at the very beginning of the pandemic, making the point that if we were going to have to deal with this, at that point, looming tsunami of the first wave, we were going to have to think about how we looked after our staff and got that right as part of the overall response to the pandemic. I think there's been a variable response to that across the NHS. I think many trusts and organisations have really put this at the forefront of their COVID-19 response. And that kind of idea that staff wellbeing is essential is, I think, one that has gained a lot of currency over the last year that we now need to build on moving forward. The downside of the pandemic response, and many of the downsides, but in particular, we did see a bit of a resurgence of this kind of, aren't NHS staff amazing? They're superhuman, they're able to cope. And again, we have to be really careful about that, because it creates that expectation. If you can't go 120% the whole time, then you might feel like you failed. And that's a dangerous place to be. So we have to be a bit aware of things like this, which feel great when you get the validation, but when we're supporting and encouraging that idea that NHS staff are somehow better able to cope than other people, we have to really tackle that and underpin it. So what should we be doing about this going forward? I think there are a lot of things that we can still do. There's a lot of good work that we continue to try to build on. And I have a lot of optimism that there is a continued focus on these issues at the heart of NHS care. We continue to work with the top level organisations like the colleges to try and make sure that we're building these kind of thinking into how we plan our workforce and how we work day by day. I think we should be encouraging every single NHS organisation, every single department to be building teaching about sleep and shift work into their induction for all of their staff, because for many staff, particularly those who work around the clock, this is absolutely fundamental. And as you saw earlier on, even small interventions like a bit of teaching, a bit of training can actually make people feel like they've been able to change the way they do that in a meaningful way. We think we need to look at the systemic responses, campaigns like the HALT one, which are all about reframing how we think about things, trying to change the way that the NHS thinks about this type of thing are absolutely essential. There's also a role, so one of the things we saw over the pandemic was the role for interventions and strategies like Headspace for individuals to try and help support them when they are dealing with significant pressures. I think we have to be absolutely clear going forward in the 21st century NHS that looking after our staff has to be absolutely fundamental to every single thing that we do. If we are under-resourced, which we have been for a very long time, our staff are the only thing that are keeping everything functioning as well as it should do. And if they are pushed and under pressure, then they are not going to be able to carry that on. So building all of those lessons that we learned during the pandemic about how to really proactively support our staff and support staff well-being, we have to continue to put the power behind that. It can't just be lip service, it can't just be superficial. Trusts and organisations have to make meaningful changes to support their staff in terms of well-being. In the longer term, I think we will start to see the use of fatigue risk management systems, which are used in other industries to assess individuals' fatigue to decide whether they're safe to be doing the job that they're doing. There are huge problems about using these within the NHS at the moment, not least the fact that if somebody is too fatigued to work, we don't have somebody to replace them with. So we have to be really careful about how we use these systems at present. At the moment, I don't think we're in a place to safely use these in an NHS environment, but we will hopefully get there. And that links to the fact that we know that we just don't have enough staff. If we are going to be absolutely honest about the care that we are delivering and aiming to deliver care to the best possible standards, we know that we have far too few doctors, nurses, healthcare professionals across the NHS to actually deliver care to the standards that we all think we should be achieving. So safe staffing is absolutely fundamental to this. There's only so much that we can do by fiddling around the margins of the resources that we currently have. If we are meaningful about making a commitment to improving patient safety, patient outcomes, and staff well-being and outcomes, we have to be really honest about the need for better staffing. That's it. I am probably not going to be around to take questions. I apologise, but I can. You can find me on Twitter if you have any questions to ask about, and links to some of the things which I've kind of touched on briefly to provide additional information about some of those points are available there. That's me. I hope that's been helpful, and I hope you enjoy the rest of your day.
Thank you to everyone that made tonight's episode possible. Whenever our scholars are thinking about complex problems facing our health systems, we encourage them to think about how they make significant change in the world of healthcare. We are incredibly lucky to have some incredible scholars in the HLA. They use the HLA as a platform to take their ideas and bring them to fruition. If you are interested in the work of the HLA, why not join us at one of our future HLA events? Why not join one of our programmes? Why not even become a HLA scholar? Thank you for joining us. My name is Johan Marlwana, the Director of the HLA, and it's a good night from all of us.